Good afternoon, everyone. I'm Michelle Hayden. I'm the Home and Community-Based Services Director for KDAD. This afternoon, we're going to talk about the renewal for the frail and elderly waiver. The frail and elderly waiver has come up for renewal, which it does every 5 years. It also would come up for renewal if we are doing an amendment to that. So part of that process is we look for public comment, and this is part of that process. Today's our first day being out. We will be here later this evening, and then we're going to Wichita tomorrow and do some public comment. We will also have some phone conferences coming up next week. If you go to the KDAD's website, you can see when those are, and you're welcome to listen to those as well. So some of this information may be a little bit dry, or a lot dry, but we do want to tell you what the changes we have made in the renewal. When I say we, I mean KDAD's, and a lot of it is just some tweaking of some definitions or some performance measures, but we will go through the waiver, and I'll explain this as we go through. So we have a waiver renewal timeline. We are, once we go through this process, we will submit our waiver to CMS. They will review it, and they will get back to us with feedback. That may go back and forth for a little while, but we hope to have this renewed by January 1st, 2020. That's our goal. I'm going to talk to you a little bit about how waivers are organized, so you kind of understand that better. I will review a summary of proposed changes, and then I'll review the changes by each appendix. And we'll also have questions, so we'll take a break about halfway through. You can ask your questions then, and then we'll have time at the end. So just feel free to ask when those times come up. So our timeline here is public comment, and is between April 16th and May 16th. And you can either give comment here, you can send an email to Anita Llewellyn. She's our administrative assistant. She's going to track all the comments that we get, or you can mail them by U.S. Post as well. We will post our public comments. We do not post people's names, so you can just make those comments anonymously. So HCBS waivers are organized by appendices, and it kind of helps you think of them as chapters, and this is how we have to go through them. They are kind of dense, but this is really our blueprint for how we run our waivers. So Appendix A is about waiver administration and operation. Appendix B is participant access and eligibility. That would be talking about who does the level of care, how you enter each waiver, what the eligibility process is, the different parts of that. So that would all be in Appendix B. Appendix C, which tends to be what people are most interested in, the participants that use the waiver, is where we have all our participant services. And so we outline each service for each waiver in the Appendix C. And so you can take a look at those. I know Lisa Churchill brought some flyers from the Ombudsman's office, which outlines the services for each waiver. So you're welcome to get those if you'd like to take them with you. We are not making any changes at this time to the services. However, with public feedback, we would need to hear from the public about what they would like to see as changes that they think would make the waiver better. Appendix B talks about participant service centered planning, service planning and delivery process. Sorry, that was a mouthful. So that is the document which authorizes all of the services for the participant in the FE waiver. Appendix E talks about participant directed services. So those are anything that's self-directed. Appendix F talks about participant rights. Appendix G talks about participant safeguards. Appendix H is quality improvement strategy by the state. Appendix I is financial accountability. And Appendix J is cost neutrality demonstration. So in order to have a waiver, we need to show that by having the waiver, we're keeping people out of institutions. It's not costing more, but either costing less or neutral to that. So, and that's, there's a lot of formulas in there. I would not be able to explain them all to you, but I can certainly get people to do so. So here's just a brief summary of some of the changes. And a lot of what we do when we start renewing a waiver is just go through, we look for grammatical errors, sentences that don't make sense, typos, that sort of thing. So some of these changes are just that, on that level. So we did make some changes to our background checks, and what that process is. We delineated more clearly as to what happens in our background check process. PCS, or personal care services, we delineated a little better about the difference between informal and natural supports, changed the language somewhat so that it becomes a little clearer. We talk about HCBS institutional transitions, which is home and community-based services institutional transitions. So if a person is in a nursing facility, they can access that to come out of the facility and be served in the community. We changed throughout the waiver sleep cycle support language. A few years ago, the name of that changed to Enhanced Care Services. It's the same service, we just have a change there with that. We also we did some changes with the Fair Hearings, updated that to match the CanCare contract. We did some updates to the definitions for abuse, neglect, and exploitation and how those are reported. Also adverse incidents, which are reported through the AIR system. We did some updates on the person-centered service planning process to make sure that we were in compliance with all the rules for person-centered service planning. We did a lot of updates for performance measures throughout the waiver, and these measures are just how we monitor how the waiver is working, and then if we're meeting our goals with that. Many of those were very minor changes. There were just maybe a little bit of language tweaking, and then any other policy and law updates. So if you go to Appendix A in the waiver, and these are all, by the way, they're all posted on our website. What you're looking at in Appendix A is the waiver description, and then just what it does, who it serves. For the FE waiver, it's 65 and above. We have no waiting list for the frail and elderly waiver. It does also talk about the HCBS settings, final rural state transition plan. And that is something that we are all working with to come to compliance with. We're working with WSU on this, and we are in the process of getting initial approval for our plan with CMS. So these are some of the performance measures for the renewal. And these again were just kind of our the qualities that we look at to make sure that we are following the waiver. So number and percentage of quality reviews reports generated by KDADS and submitted to the state Medicaid agency, and then the state Medicaid agency is KDHE. They are the single state Medicaid agency. Number and percentage of waiver amendments and renewals reviewed and approved by the state Medicaid agency prior to submission to CMS by the state Medicaid agency. Number and percentage of waiver policy changes that were submitted to the state Medicaid agency prior to implementation by the operating agency, and number of percentage of long-term care meetings that were represented by the program managers through in-person attendance or written reports. So these mostly have stayed the same. There's a little bit of difference in the in how we worded that. So we have the old performance measure on the left, and to the right is the new performance measure.
Michelle.
Yes.
Operating agency, is that KDADS?
That's KDADS, I'm sorry. Yes, KDADS is the operating agency. So Appendix B talks about the participant access and eligibility, and that is the folks that we contract with that does level of care. So in the case of the frail and elderly waivers, the AAAs currently have that contract, the area agencies on aging, and the ADRCs are housed within the AAAs, and they do all of our level of cares to ensure that people are qualified for the threshold to meet frail and elderly. Part of that is age, and then part of that is through their assessment. We talk about reserve capacity there, and reserve capacity is we do set aside certain slots for people. And reserve capacity, that would be like military families and children in DCF custody, as well as HCBS institutional transitions. And, again, there's no waiting list for the frail and elderly waiver, so, that really doesn't have as much effect here. So here's the performance measures that we have done some tweaking to. We've changed this from all waiver participants to newly enrolled waiver participants that we are looking at determining to meet level of care requirements prior to receiving HCBS services. Our quality team pulls a number of reports every quarter, looks at that to make sure that the ADRCs are making sure that they are doing that properly. Also, we changed from all levels of care determined to initial level of care, determinations. So we were looking at all level of cares, now we're just looking at the initial ones to make sure those were done properly. We have removed another performance measure, which is to make sure that reassessments are being done within 365 days. We are still tracking that, or we are still requiring the ADRCs to do that, but we aren't tracking it as a performance quality performance measure. And we've removed 3 of these old performance measures: number of percent of all level of cares, determinations made by qualified assessor, number of percent of initial level of cares, determinations made where the level of care criteria was accurately applied, number of percent of third-party contractor level of care determinations found to be valid, and then we just changed this one down at the bottom, number of percent of initial level of cares determinations made by a qualified assessor. So for Appendix C, this is where the participant services lie, and this is usually what people are most interested in, or at least our users are. We did a little tweaking to some service definitions. We have all the same services that we have had before. Sleep cycle support has been changed to enhanced care services, but it's still there. We did some delineation on the informal and natural supports for personal care services. Talked about provider types a little bit in here, background checks, and again, performance measures. So the old performance measures we were looking at the number of licensed and certified waiver providers, applicants that initially met licensure requirements. Now we're looking at number and percent of newly enrolled waiver provider organizations that are licensed, certified by the state, that meet all the licensure and certification requirements and other standards. We're also looking at number and percentage of enrolled waiver provider organizations that are licensed, certified by the state, that continue to meet all licensure, certification requirements, and other standards. And number and percent of newly enrolled waiver provider organizations that are not licensed, certified by the state, and meet all provider organizational level waiver standards. So this process is, we do pull all that information to look at it. Providers have to enroll both with KMAP and they also need to enroll with any of the MCOs that they are planning to make services for, and they have to be credentialed through that as well. So number and percent of enrolled waiver provider organizations that are not licensed and certified by the state and continue to meet all provider organizational level waiver standards, and number and percent of enrolled providers that meet training requirements as defined by state policy. So we are looking at these as performance measures to make sure we have the providers are qualified to provide the service in accordance with the waiver. So does anyone, do you guys have questions? I'm gonna let Seth get up here.
Thank you, Michelle. So, as you've already heard, you can submit questions and feedback by email. That information is on the third slide. It's in your handouts, and you can do that now or following the meeting. You can submit questions or feedback on the note cards at your table and either leave them there or ask one of our staff folks to read them. Or, since you're here in the room, if you have questions or feedback right now, raise your hand or shout, and one of our mic runners will bring a microphone over and hold it for you so we can get that question. Danny, looks like you got one.
Hi, I have a question or maybe a comment, and it's about the services offered on the FE waiver. Like you said, enhanced care services or overnight care, what used to be called sleep cycle, is offered on the FE waiver and has the same definition as the service that's offered on the PD waiver, IDE, and the TBI waiver. But for some reason, there is additional criteria for FE waiver folks. They have to meet 5 of 6 listed criteria. And I guess my question is, why? Well, why does it exist for the FE waiver? The only purpose to me it seems to serve is to just make it really hard to get overnight care on the FE waiver. And I guess my proposal would be maybe to get rid of that crisis. It's called a crisis criteria in the waiver. But I was just wondering if you could perhaps speak to that or consider maybe doing away with it.
Okay, well, thank you for that question. As to your historical question is why we have that, I'll have to say that I don't know. I can look into that, and we will take a look at your suggestion to change the criteria in order for people on this waiver to access that service.
Yeah, and I appreciate that. It just seems to me that it would make sense for it to be the same, at the very least, right? The same across the waivers. There doesn't seem to be anything in particular about folks who are eligible for the FE waiver, why they would need the service just as much as, say, someone on the PD waiver or another waiver.
Sure.
So that's just my comment or suggestion. I'd be happy to, I'll put this in an email too, just so.
Thank you, please do. We're gathering these comments here. And I've heard that comment before.
Okay.
So
good.
you're not the first.
Okay.
So,
I actually have a couple of questions and then one comment, if I could, please. The questions are related to the level of care assessments and what you're no longer required to do. And if the ADRCs continue to remain at the AAAs, that makes sense to me. If there is a new contractor, will you then begin again reviewing level of care assessments and their, whether or not they're appropriate? Accurate is the word that I'm looking for.
I'm sorry, what was the last?
Accurate is the word I'm looking for.
So we do review the level of care assessments. We do a quality poll every quarter of so many assessments. So we are going to be watching that. And I do not know, Todd, do you know any more about the contractor? Are you involved with that?
With the ADRC?
Yeah.
Yeah, it hasn't quite been, the new contract hasn't quite been finalized, but that should be done in the next few weeks.
So I can try and get some more information on that, how they're moving forward. We do have an expectation that they are doing their level of cares annually and that they are accurate, but that won't be one of our performance measures.
Yeah, and the only reason I'm asking about that is obviously the ADRCs have some history with this now and some competence with it, so if we find ourselves looking at a new contractor, it seems like we might want to have a higher level of scrutiny if that occurs.
And I'm thinking that would be built into the contract, but I'm not sure that they're gonna be a lot more interactions to make sure things are going smoothly, and check-ins with KDAS to make sure that everything's going the way it should be. And we will be monitoring, if people are coming who did qualify 1 year and suddenly don't qualify again, looking at that to see if that's a problem with how it's administered or what the deal is. So we'll take a close look at that. Thank you.
Okay, and my other question is related to providers, and I might just not understand what you're talking about, so maybe you can clarify that for me.
Okay.
On the performance measures that are specific to providers, so the last couple of pages that you covered, what are these changes actually trying to address?
They're trying to address the process for people to, or for providers to provide the service. They're trying to make sure that they're meeting the standards for whether they're agency directed or self-directed or licensed or non-licensed, that they meet all the standards that the waiver sets forth. So part of that process for licensed providers, they do have to go through KMAP and get the meet some basic qualifications there. And then the MCOs also have to do a credentialing process to make sure they meet all the requirements of the waiver.
And is there some intersection here with network adequacy?
I hope so. Yeah, that's an issue.
Okay.
Because the MCOs are having to, she works on this a lot. So we're really trying to get some better accountability about network adequacy so that we can really look at what the network actually looks like and where there are holes and what we need to do to get an adequate network of providers.
And my last is just a comment, and it has to do with older adults and dementia,
Okay?
and not adding services to the waiver renewal. Last year, there was a work group convened by the governor. There are recommendations out there about additional services that are needed for people with dementia.
Okay.
We know that people with dementia are at increased risk of institutionalization when caregivers are not able to sleep at night, in addition to caring for someone all day.
Okay.
And so particularly that enhanced night service, whether that is in the home or out of the home, if we looked at 24/7 day services, or if we looked at more sleep cycle support in the home, that could have a huge impact for people with dementia not being institutionalized. So,
Are you able to share with me those recommendations that you came?
absolutely.
Yeah, please do that. Send that to me or to Anita Llewellyn, whoever, so that we can take those in and look at those.
Thank you.
Thank you.
Other questions or feedback? Raise your hand or shout. I'll give it 15 seconds. All right, and Michelle, if you're ready, let's hear the second part of the presentation.
Thank you, Seth. So if you look at Appendix D, the participant-centered service planning and delivery, this is what Appendix D talks about. We did make some changes with the person-centered service plan and some performance measures. So the new performance measure is, we have a new performance measure, and it's the number of person-centered service plans that contain the signature date and signature of the participant or their legal representatives, applicable service providers and care coordinators. We have removed number percent of waiver participants or their representatives who were present and involved in the development of their service plan, number percentage waiver participants whose service plans were developed according to the processes and the approved waiver, and number and percent of service plans reviewed before the waiver participants' annual redetermination date. We also removed number of percent of waiver participants with documented changes and needs whose service plan was revised as needed to address the changes. We changed the second one here to number and percentage of person-centered service plans initial and annual updates signed and dated with contractual timeframes. We removed the third one, number of percent of service plans reviewed at least every 90 days. And the fourth one we changed to number and percentage of waiver participants who receive services and supports as authorized on their person-centered service plan. We removed two more, number and percent of survey respondents reported receiving all services as specified in their service plan. Number and percent of waiver participants whose record contains documentation indicating a choice of community-based services versus an institutional alternative. We changed number 3 to, or the third one down from number and percentage of waiver participants whose person-centered service plans address participants' goals, and number and percent of waiver participants whose person-centered service plans address their assessed needs and capabilities as indicated in the assessment. We changed the first one to number of percent of waiver participants whose person-centered service plans address health and safety risk factors. And the second one to number of percent of waiver participants whose records contain documentation indicating a choice of waiver service providers. And number and percent of waiver participants whose record contains documentation indicating a choice of waiver services. And then number and percent of waiver participants whose record contains documentation indicating choice of either self-direction or agency-directed care. So with all those performance measures, basically what we're looking for is that people are participating in their service plan, they've signed off on their service plan, we have to have some indication of whether they have choice offered to them, whether that's self-direction or agency-directed or the different service providers. They also need to make a choice between institutional versus community care. So those are just indicators that we get on paper basically that tell us that people are getting all their rights protected for service planning, and that the MCOs are taking them through those steps and making sure that they're signing off. So Appendix E, we made no changes to Appendix E, which is participant-directed services. Appendix F, participants' rights, that's the fair hearings, where we talk about that. We cleaned up some language in there, make sure that we met the same criteria as 1115C and Carroll Ring. Appendix G talks about our AIR system, which is a system that we report abuse, neglect, exploitation, can be reported in there, as well as adverse incident. And we have some performance measures around this. We're looking at number and percentage of waiver participants who have disaster backup plans. So we ask that everybody that is using services have a backup plan in case something goes wrong, caregiver doesn't show up, whatever, so that we maintain some health and safety. Number and percentage of unexpected deaths reported to KDADS for which review resulted in identification of non-preventable causes, and number and percentage of unexpected deaths reported to KDADS, which review investigation followed the appropriate policies and procedures, and number and percentage of preventable unexpected deaths reported to KDADS resulted in a state-issued corrective action plan, otherwise known as a CAP. We have a few more. There's a number and percentage of adverse incident reports reported to KDADS year to date, which were initial and then reviewed within required timeframes. Number and percentage of reported adverse incidents reported to KDADS for which review investigation followed the appropriate policies and procedures. We removed the third one, which is the number and percentage of waiver participants who receive information on how to report suspected abuse, neglect, and exploitation. And we have a newer one, which is the number and percent of DCF screen out, substantiated or unsubstantiated adverse instance where KDAD's subsequent review followed the appropriate policies and procedures. We removed the top one there, which is number percent of restraint, application, seclusion, or other restrictive interventions that follow procedures as specified in the approved waiver. We changed the second one to number percent of unauthorized uses of restraint, applications, and seclusion that were appropriately reported to KDADS, as well as number 3 there, and number and percentage of waiver participants who received a physical exam during the 365-day period. Just kind of changed the language there to be more clarified. I do need to point out that on the FAA waiver, there is no seclusion, restraint of any kind that is allowed. We did want to standardize the performance measures across waivers. We do have one waiver that does allow for that, and that's the IDD waiver. But there's a huge protocol they have to go through before any of that can happen, and then only in certain circumstances, and that has to be closely monitored. But we do, if it should happen on the FE waiver, we would want to know about that and make corrections there. But it's not allowed. It's not anything that can be done. Appendix H is our quality improvement strategy, and that's just a strategy that KDAS and KDHE use to monitor for quality. Appendix H is financial accountability. We have a few performance measures there that we tweaked. There's number and percentage of clean claims that were paid by managed care organizations with the time frame specified in the contract. That's to make sure providers get paid timely. Number and percentage of payment rates that were certified to be actuarially sound by the state's actuary and approved by CMS. And then we removed the third one there, which is number percent of provider claims that are coded and paid in accordance with the state's approved reimbursement methodology. So that brings us to our last appendix, and we don't have any changes there.
So again, you have an opportunity to ask questions or provide feedback about anything you've heard in the presentation. If you'll indicate that you have a question or a comment, we'll have a microphone brought and held for you. Lucy, there's one at this table here.
Michelle, on the, I think it's 11 on my page 11, it's the performance measure on waiver participants who have a disaster backup plan. How do you measure that?
Actually, quality looks at, they should be developing that at the same time they're doing their person-centered service plan. We measure that to see if it's present. If they have something that works, let's say that, someone is dependent on a certain caregiver to come in and help them with certain things, that caregiver can't come in, and it would say my daughter-in-law may come over and help me in those times. It's just, it doesn't have to be very extensive, but they just have someone to cover them for at least a short amount of time until other things can be put in place.
Thank you.
Michelle, on the issue of restraint, one of the things that we've been concerned about is the use of antipsychotic drugs on adults with dementia. So is that addressed at all, the chemical restraint issue in the measures on restraint? Is that anything that you'll be looking at?
I'm going to have to get back to you on that. I'm not aware of that. But, I'll just get back to you. But thank you. I know that's a big issue in nursing facilities.
It's actually a growing issue in the community, about 5% over a 4-year period.
Sure. Okay. Thank you.
Others in the room with a question or a comment or something on a card you'd like us to read for you? office if you have a unique situation or a personal situation. I want to thank our professionals who are here to provide translation services. Thank you for being here. So KDADS will be continuing to review and respond to public input before submitting the renewal to CMS. There continue to be additional opportunities for feedback by email or mail. There are conference calls that are scheduled if you'd like to hear this information again, or if you know other people who might want to access those. Those are coming up on April 29th and 30th. If you would like to come back into this room, we'll again be talking about the frail and elderly waiver at 6 p.m. in this space. Feel free to send people. Please do remember to fill out your evaluation form. This helps us to know if we were successful in our attempt to make it easy for you to ask questions and provide feedback in this process. Thank you all for investing the time for being here today.